Inequities in health are unfair, unnecessary, and avoidable. New York City is one of the most unequal cities in the United States and one of the most segregated. It is no surprise that these everyday realities are reflected in our health. A more deliberate effort to name and address these disparities will frame all that we do. And that is from my health commissioner, Mary Bassett. So as the deputy director at the Center for Health Equity, we are really charged with looking at health inequities from different prisms. Historically, the New York City Department of Health and Mental Hygiene has used the term health disparities, has used many different terms to show and highlight that there's an unequal situation in our neighborhoods, and certain communities have more negative health outcomes than others. But there has never been a division that has really been focused on addressing those health inequities head on. You have many different divisions that take on, let's say, hypertension, chronic disease. You look at the built environment, you look at environmental health, you look at mental hygiene. But, my colleagues work very hard in those areas, but there's never been a focus on looking at what causes those health inequities to exist. So the Center for Health Equity has been involved in a lot of different initiatives with many of the folks in this room. But in the last year, we have really been able to quantify what is our focus. And it's important to give context as we start this conversation. I'm going to be looking at my iPad because as I get older, I forget my notes very well. I used to be, as Ray can attest, Ray's known me for a long time, I used to be good off the top of the head, but so times are changing. So we have 4 specific approaches to advance health equity. We are supporting the health department's internal reform and becoming a racial justice organization. And what that means is, we are staffed up to lead conversations on racial justice, social segregation. It is important for a division to not stand alone by itself in an agency of 7,000 people and talk about racial and social justice by itself. It is imperative that other divisions and bureaus, when they hear us speak, they have an understanding of where we're coming from. So that's what we mean by internal reform. We're investing in key neighborhoods. Historically, for those of you who are familiar with the health department, we've had district public health offices in 3 specific communities for over a decade. They are in East Harlem. They're in, we call it the South Bronx, but it's really more for Crotona, and some people don't consider that the South Bronx, depending on how the Bronxites in the room. And we also have an office on Bedford in North and Central Brooklyn. In addition to that, we in the next several months are going to be expanding our operations to basically give back more to the community. The health department's had a portfolio of buildings of over 40 to 50 at a given year. So in 2016, we're going to be opening this new initiative called Neighborhood Health Hubs. And Neighborhood Health Hubs are our commitment to advancing health from the standpoint of having federally qualified health centers, community-based organizations, and community leaders in our buildings working to address health inequity. So if you think about it, we have the opportunity in the health department to really do a lot of evaluation and research, but rarely do we have the opportunity to pull everybody together and work together. Our neighborhood health hubs provide us an opportunity to do just that. We are also working on truly developing what partnerships really mean. So if I say I'm a partner with the Friends of Brook Park or HPD, we have to define what that partnership means. Historically, we used to always rely on the fact that we're great data collectors and we're able to provide folks resources as it pertains to health data outcomes. We want to do more than that. We want to build up organizational capacity. I'll give you an example. Yesterday there was a grant announcement coming from a foundation, a really good foundation. We used to jump at those grant announcements. We used to say we're going to apply for this grant. But we're a bad NGO. We don't do community-based work well. So instead of taking these grant opportunities, we want to figure out a way to extend those opportunities to community-based organizations that do the work well, and to figure out our role and our niche, which I think is really looking at providing technical assistance as it relates to policy and systems change, but also looking at evaluation from classic public health indicators and providing that support. And finally, we're looking to transform how we do our data collection and storytelling. So right now, for those of you who are familiar, we've released our community health profiles. It's a big deal for the department. It's been 6 years coming. The community health profiles, for those of you who are looking at it or are not aware of it, it's a neighborhood snapshot. It gives you an idea what health inequities exist, But we also want to work on not leaving that information for interpretation. We want to work with community-based organizations and city agencies and tell the stories of like how we're going to make that actionable. That data and information cannot stand alone by itself. Because when we have these discussions on public health, people are looking at us and saying, okay, so you present me that negative data, what are you going to do? And that has to change. So that is a quick snapshot of what the Center for Health Equity engages its work on an everyday basis. Now I'm going to really lightly touch on, and my background is not in urban planning, but in the last year we've hired a couple of urban planners who are in the room, and I'm very grateful to both of them, and they know who they are, because I've become much more reflective on the processes that have taken foot in New York City as it relates to zoning. Historically, my participation in zoning has been as a representative, as an elected official, or has been as somewhat of a sharing health-related information, but I never really understood the context of zoning. I do recall Pathmark because growing up in a barrio in the Bronx, I remember that was a big deal. I remember it was a huge deal. And when it opened up, it was a culmination of a lot of hard work from a lot of old school folks in that neighborhood who are now being pushed out of that neighborhood in many different ways. So, for me, seeing Pathmark close and having a food conversation today and seeing everything that's happening across the city, whether it be in Jerome Avenue or Bed-Stuy, where communities are banding together and saying, this process has to change, it has to be a little bit different. What is the public health contribution to that conversation? As Nevin mentioned, we participated greatly in the design of Fresh, and Fresh has its pluses and its minuses. But we have to go a little bit further. So when we think about zoning, I think we have a couple of opportunities that I just want to lay out there for context. We believe that that the neighborhood planning process that is taking place in the neighborhoods across New York City should be formalized. Right now, it's kind of being done in an ad hoc way. It's attached to the zoning efforts that the Department of City Planning is leading. But when you have conversations on transportation, on health, on education, that has to be formalized because it doesn't have a landing spot. So we and the health department believe that if we formalized it, we can even take a greater role, and I think other city agencies can be more responsive to the public health, to the public conversations that are taking place. We believe that utilizing the community health profiles that we have just released can be the framing documents for planning processes. So when you look at inequities and you look at the planning proposals that are moving forth and health inequities, I should say, if we're not addressing food access, active living, then we as a city agency have failed the community in a lot of ways of not bringing that to light as something that needs to be worked on. And I believe that if my colleagues and other city agencies, if they were to see how the investments in prevention actually has a windfall for the city of New York, if you look at the Affordable Care Act, if you look at the Medicaid redesign that has taken place across the state, there are benefits for using our health profiles as a mechanism for a community planning conversation. And we think, requiring health impact assessments is something that should be standardized. Health impact assessments are used from King County to Philadelphia, and yet in New York City they are looked at as another process that's going to slow down development. I'm not a developer. There are folks with those experiences around, but this is a hot property. I don't know if health impact assessments is going to slow that down too much. And then, finally, I think that when we look at innovation, we can look at a couple of localities. In Minnesota, they've recently updated their urban agriculture text amendments and zoning code. This is the first time they've amended something since 1963 in their zoning laws. I think in New York City, the zoning laws haven't been amended since 1968 or 65. Oh, tell me, somebody educate me.
It's every day practically.
Every day practically?
Yes.
Okay. Depending on who you speak to, people have different interpretations of what has been amended. What I'm saying is, can we initiate that same dialogue that has happened in Minnesota? In the LA County Public Health, if you're familiar with LA County has worked on creating a health agenda that involves planning, that involves transportation. And we were on a conference call with LA last week or 2 weeks ago, and they basically said, one step at a time, 2 minutes, one step at a time. take a project, lead with that project. Don't have no overarching big initiative that you can't see any progress. So we in city government need to think about, if I'm putting on the table, how can we utilize health profiles, health impact assessments, how can we come together? And that's what it really comes down to. A lot of the zoning changes that have taken place in Minnesota and also in Baltimore and King County, it came out of legislation, mayoral mandates. You know, it's a part of their agendas. And I think we in city agencies can maybe set forth an agenda without having it being mayoral approved. I think it could be mayoral reviewed, hopefully for approval. But we have to look at the fact that we have stark inequities in the city of New York as it relates to public health outcomes. Gentrification is happening across the city. We as an agency need to reevaluate how we look at assessing neighborhood health with all the changes that are happening. But we also have to think about how we can hold each other responsible for making our goals achievable. And if we want to decrease infant mortality, if we want to decrease hypertension, we have to work with the planning community just like we did 100 years ago when we were fixing water and sanitation and everything under the sun that needed to be worked on. That relationship can happen again. So thank you for that introduction, for my opportunity. I want to hand it over to Daniel.